I'll tell you a little bit about myself. I'm not a clinician. I'm an engineer. And I'm a mechanical engineer, actually. So it has been a long road for me from studying mechanics of materials and solid mechanics somewhere in the past to actually do today work which is much more on the biology side of research. But I'm going to walk you through this road and show you basically the highlights of 15 years of research in my lab, which I'm going to squeeze into 45 minutes approximately. But you're most welcome to talk to me during breaks, or then even contact me later via email or whatever. And I'll be very happy to clarify things or to address you to papers, etc. In my other hat, I'm also, as was mentioned, the president of the European Pressure Ulcer Advisory Panel, which is really a great body in the sense that it connects scientists like myself, clinicians, the industry, and patients to form this rectangle of network, collaboration, new ideas, and feedback, which are really essential in this field. So before I forget it, I encourage all of you to also attend our meetings, both our focused meetings, like the one that we just had in Southampton, and we'll have another one in 2016 in Berlin, but mostly our annual meetings. So every year we have a meeting in a major city in Europe, and this year is going to be in Stockholm at the end of August. Really a great opportunity to learn about what's in the frontier of science and clinical practice, particularly the guidelines that we are responsible for, together with our sister organizations in the States and in Australia, and also in Asia. So let me start by just highlighting some facts and figures that are relevant here. I'm sure that I don't have to tell you that pressure ulcers are an important problem. And I also don't need to tell you that even with the best medical treatment that money can buy, people can sometimes still lose their life as a result of a pressure ulcer. And that's probably the most famous story, but there are a lot of these stories every day. And besides human suffering, there's also the costs. And I've checked the numbers in this country, and it's huge amounts of money that are spent every year to treat something that we might have been, we could prevent probably. So why spending all that money on something that you can prevent? But in order to prevent, you need to understand. So the approach of my research was always to understand the etiology in order to be able to, at the end of the day, come up with practical solutions. So that's the kind of engineer that I am. I'm a very practical person, and I'm trying to understand what's going on there that actually is causing the injury so that I can do something to prevent it. One of the difficulties that I'm facing, particularly when trying to get money for my research, because as you may know, research also costs money, is to convince authorities in Israel or elsewhere that pressure ulcers are not just a problem of terminal patients. They are not just appearing at old age. They are a huge problem in many populations, including young ones, including people who normally they're healthy, well, they can suffer some kind of a disorder that will, for example, require surgery. But during the surgery, they can't feel, they can't move, and they get a pressure ulcer. Spinal cord injury, that has always been the focus of my research, and you'll hear about it today a lot, because these are typically young individuals who have, like this guy here, like Christopher Reeve, at the time when he was injured, who have many, many years in front of them, and we do want to give them a good quality of life. And this specific population also have some characteristics that are unique in terms of how their body respond to the injury in the short term and in the long term. Other disorders of the neuromuscular system, again, young individuals, post-brain trauma, post-stroke, many, many different conditions with one common devastating, potentially devastating consequence. What we have achieved in the last decade, I would say, is a consensus, a worldwide consensus, that there are different types of pressure ulcers. And if I would need to roughly divide them into types, I would say there are these superficial pressure ulcers and there are deep tissue ulcers, or deep tissue injuries, as we call them now. And superficial pressure ulcers, which by definition are lesions of the skin, are typically occurring when there is contact and friction with the surface, and that contact is shearing the surface of the body, that is the skin, and basically is causing tears, and that is particularly the case when the skin is a little bit wet, say due to incontinence problems or even sweat. And then there is these micro tears into which bacteria may penetrate, and then there is an infection. And honestly, that's not a big deal. Because if the patient is getting proper care, and if someone, either the patient himself or someone who's taking care of him or her, is looking at the skin, with a little bit of experience, that's visible and that's treatable. Unlike this thing here, which is much more tricky, because this thing occurs internally in the body. So basically what you have, then this is a classical mechanical engineering problem, you have this rigid body, a bone, a sharp bone. So in this case, for example, of a sitting subject, that would be the tip of the pelvic bone, so the ischial tuberosity, compressing and deforming soft tissue layers. The first tissue that it meets is the muscle, the gluteus muscles. These are the biggest muscles that we have in our body. And if you imagine like a pencil that is pressing against a foam, just under the sharp pencil, you'll have a lot of deformation of the foam, right? And as you move away from that contact point, the deformation level will decay. So the same thing happens here. So what the cells in the tissue here feel is huge, large deformations. And these large deformations are affecting their viability, and I'll tell you later why. And at some point, they start to die. And when they start to die, because they can't resist it anymore, they can't tolerate it anymore, they take their friends with them. So we call it necrosis and apoptosis. So some of the cells die. It activates a cascade of events that cause other cells to kill themselves. So this is apoptosis. So this thing starts to progress now and also invade the more superficial tissues. The patient can't feel anything, typically, because there is a neural impairment. so he's not or she's not sensitive. And then at some point, someone will notice that there is a blue or a black or a purple spot on the skin, but by that time it's too late. And in most cases, it will break down, and then you'll see a wound that goes from the skin down to the bone, what we call a grade 4 pressure ulcer, but it actually started inside. And we try to understand how you can avoid, or at least minimize, the occurrence of these cases. Even when it's nearing the surface, and there is these color changes that I've mentioned, inexperienced staff, nurses, can still confuse between the two. They can still confuse between, and I've seen it happening, between some skin irritations and a deep tissue injury which is evolving. So it's also important to understand risk factors. So who are the patients at risk? Where you need to actually actively look for the signs of these things to happen. And then we also look at potential treatments and even before treatments, early diagnosis. So to stop this spiral of damage while it's happening and before you get this. So this is the problem that we look at, deep tissue injury. And our hypothesis in my research has always been that it's all starting on the cell level, and it all connects to these levels of deformation that I've mentioned. And these deformations are affecting the cells. They're affecting them mechanically, so directly distorting them, but they're also affecting them chemically. So we are always speaking in biology about homeostasis, so biological equilibrium. So they're affecting that biological equilibrium. And that eventually manifests at the level of the organ, so at the level where you don't need a microscope anymore, it manifests eventually as an injury. And as I was mentioning, we try to look at the biology, even if in the level of individual cells, at the level of tissues, and then at the level of the human body, to understand all these processes and to try to come out with prevention means. And actually, we do it the other way around. So we like to think of it as a kind of a pyramid. We call it hierarchical approach. So there's a hierarchy here. So at the bottom, there is the basic unit that is constituting a tissue, which is a cell. On top of that, there is the more complex structure of the tissue. And on top of that, there's the more complex structure of the organ. And I'll take you through the journey looking at each of these levels. And then once we get here, I'll take you back here, and we see how it all connects together. So I'll start, as I mentioned, in the organ level, or in the human body level. The first thing that engineers would like to do is to measure. So if we think that deformation is the cause of the injury, we'd like to be able to measure these deformations. So how do you measure deformations internally in the body? We use a lot of imaging for that, particularly MRI. And we had access over several years to a seated MRI. We don't have that machine anymore, unfortunately. But while we had it, we were working with it almost around the clock to get data out of it. And in these seated MRIs, or open MRIs, sometimes you call them, there is a space in between two magnets. That space is designed for interventions, so like minimally invasive surgery. But we use that space differently. We used it to look at how the body deforms, how the tissues are distorted when the body is carrying loads. So normally in an MRI, you would just lie down. But in this MRI, you can sit. You can even stand in it. And we did some studies in standing patients, for example, in amputees. I'm not going to speak about that, but you can look for that in the literature. The study that we did here was with seated patients where we had them sitting on a rubber tire. So the tissues, the buttocks was basically in the air, so not carrying any loads. The loads were all lateral. And you can see these tissues. This is just one of my students, so she's perfectly healthy. You can see the muscle mass. I was mentioning that these the gluteus muscles, they're the biggest muscles in our body. You can see them here. This is the sharp ischial tuberosity that I was referring to. And the white stuff here is fat. Now you take this rubber tire away and you let the patient sit either on a rigid surface or on a foam cushion. You get something like that. It's the same anatomical cross-section, right? Same buttocks, same anatomical cross-section. Look at what the muscles are doing. So they're basically squashed. That's normal human anatomy. And you don't need any engineering, sophisticated calculations to say that, these muscle tissues are decreasing by like 50%, say, in thickness under body weight. The fat thickness is also decreasing. You can see that. So there is large, what we call as engineers again, large deformations here. But if you add computer modeling to that, then you can also look at the localized levels of deformations. Because what we do here is we kind of average with our eyes. But locally, again, think of that example with the pencil and the foam. So locally, there would be very high deformations just at the contact between the bone and the tissue. And then they would decay as you move away from the bone. And with engineering analysis, this is a method which is called finite element modeling. It's very popular in biomechanics, which is the field that I'm in it. And in finite element modeling, what you do is you treat very complex structures like the human body by means that were basically designed to analyze engineering structures, for example, bridges or machine parts or whatever. So here's my previous life as a mechanical engineer. And you basically reconstruct the structure in a virtual environment, so in a computer, and you divide it into small elements. These are the finite elements. And the computer basically solves the loads on each of these simple elements and the interaction between them, and then comes up with these pictures, these diagrams, these maps of load distributions. So this is going to be very useful, and I'll show you more examples of that along the way. But what I'm trying to show you here is that the levels of deformations, this is the red stuff here, the red spots. Red is not good, like the cooler colors are okay. The warmer colors indicate high deformations. So the highest deformations are around the bone or just under the bone. Now, I've told you that we did a lot of these MRI studies, and some of these studies we've done on healthy subjects, and some of them we've done on patient populations, and I've told you already that we are focusing on spinal cord injury. So this is again a healthy image or an image of a healthy person, and these would be images for spinal cord injury patients. So you can see what's going on there. So the disuse of the bones and the muscles is affecting the structure of the buttocks. So we all know that there's muscle atrophy, disuse-related muscle atrophy, much like what happens in microgravity environments, so like in space. Because you don't use these muscles, they basically are wasted, and fat invades into these muscles. So you can see these fat strips that are going from the fat into the intramuscular environment. And basically what you have now is typically a heavier patient, because typically these patients are now less active, so they gain weight. They lose muscle mass, So these muscles become very thin, and they deform easily, right? Again, back to the examples of the pencil and the foam. So if there was a very thin foam, it would be deforming easily. So this now very low thickness of a tissue needs to carry all that weight, and it's also becoming softer because all this fat is invading in, and fat is softer than muscle. You know that probably when you clean your chicken breast for your lunch or whatever, and you take away the fat, you probably feel that it's softer, right? So the muscle is becoming softer, it deforms more, and then all these, what we call stress concentrations, are increasing, right? Sometimes the muscles are almost gone or are gone. The point that I'm trying to make, that this is a completely new structure now. It's not a normal buttocks anymore. It's what we call these pathoanatomical changes. They create a new structure. The bones, by the way, are also changing. This also a disuse response. They become more flattened. You can see that, as opposed to here, which is more round. That's also a response to the disuse. There is a loss of cortical bone mass, so the cortex of the bone is wasting as well. New structure, new mechanics. And basically what I've explained to you about the muscle can be measured with this finite element modeling. So we look, as engineers, we look at stress levels or at strain levels. Strain is basically a dimensionless measure of a deformation. And you can see that it doesn't really matter on which particular engineering measure you're looking at. There's always a rise in the level of internal tissue loading as a result of these changes that are going on there. You can do a lot with these MRIs. You can look at the effect of posture. So if we think, again, about stroke patients or brain trauma patients, they tend to sit like tilted to one side. What does it do to their internal tissue loading? You can directly measure that in an MRI. That's also important if you want to plan interventions. If you want to plan, so I'm an engineer again, right? So if I want to think about some automatic system that moves patients, or some support surface that will fix your posture, maybe to prevent pressure ulcers, then I have to know how much to move in order to minimize these tissue deformations, right? So you can actually measure that with imaging. You can look at what a cushion is doing to your internal tissue deformations. Well, people are doing it with pressure mats, right? Doing it with a pressure mat is almost like, trying to analyze what's going on there with your ears covered and one eye covered. There's so much information that is missing because you just look at the skin, where everything else is, all the important stuff is happening in there, and you're just looking at the skin. And basically what you need to do is to look inside, which is what imaging allows you. And you can actually take different products. I didn't put names here intentionally so that I don't get sued by anyone. But you can take different products, put them in the MRI, and measure these tissue deformation levels. And you can see that there are some differences across products. Not huge, but some differences. Well, the first time that I've looked at that data, I thought, well, that's too small. Does it matter? Does it matter if it's, deformations of like 70% or 60%? Well, it matters a lot, and I'll show you later on why. So this combination of imaging technologies and computational modeling, computational simulations, state-of-the-art methods really of computational simulations give us much power now in research, the kind of power that we didn't have just like 10 years ago. So if the early modeling efforts of this problem were to just look at flat surfaces and what happens with flat surfaces, now we have the power, computationally I mean, both in terms of hardware and software, to look at how very complex support structures perform. And the Rojo cushion would be a good example for that. So these are simulations that we have developed together with Rojo to look at how their cushions are functioning, not in terms of what's happening on the skin, because that only tells you what happens on the skin, right? But if you want to look at deep tissue injuries, for example, you have to look here. You have to look at these interactions between the bones and the soft tissues. And you can compare that with other technologies. I'll get into the details of this study after the coffee break. But at this point, I just want to show you that now we have computational capabilities to actually explore these internal interactions which we didn't have before. And another very important point, this is not Walt Disney, so this is not like Mickey Mouse. This is physical interactions that take place in the body while someone is being seated or is sitting on a cushion. And this is for a certain anatomy. You can do it for other anatomies as well. You just import them from the MRI scan of a real human being. So I hope that by this time I convinced you that we can measure internal tissue loading magnitudes and distributions, and that it's important. But what do we do with this information, really? Is say, the 1 kilopascal or 10 kilopascal that I'm calculating with my finite element simulations, is that good? Is that bad? How much sitting time will it buy for you? Well, there's no other option but to go to another type of modeling systems to answer that question, which is what we call living model systems. Living model systems can be simply animal models, and that's the way I started. These are really unpleasant experiments to do. You need to anesthetize an animal to cause a pressure ulcer in it and to know what are the conditions that cause that pressure ulcer. So, for example, what was the level of tissue deformations or pressure that you applied on the tissue, say on exposed muscle tissue, in this case of a rodent. And you need to know how much time you applied that pressure. And then you can do histology to look at whether the tissue survived or not. And if the tissue did not survive, then you know, so this kind of necrotic tissue that we have here, then you know that for this certain combination of exposure to load over time, the tissue did not survive, and vice versa. If the tissue survived, you know that for the given loads and exposure times, that would be okay, at least in the rat. So if you do many of these experiments, and you plot the data of these experiments on a graph, you can eventually distinguish between all the cases where you had irreversible tissue damage and the cases where you didn't have that, and you can draw a line to distinguish between all these cases. And then you get what we call a tissue injury threshold, which is a threshold that distinguishes between times and pressures which are basically, essentially the high levels of pressure or deformation or whatever measure of load, and time exposure that caused the injury, and those that were not causing the injury. And this is really nice because you can plug it in these computer simulations and then actually translate these loading levels to a risk measure. So that spot in the tissue would be at a high risk for a pressure ulcer if that would last for like 2 hours or 4 hours. Now you can see basically, this is quite an important slide, you can see basically that high loads for even very short times cause almost instantaneous injury. That would be basically the failure strength, again, mechanical engineering, the failure strength of a tissue. So that would be something, you can think about acute, like trauma, like a car accident. You have a lot of force applying, acting on the tissue in a very short amount of time, and there is an injury. And so if the forces are low enough, there would be no injury at all. And I always give the example of my watch here. I wear it like for 23 hours a day when I work. And it doesn't cause me a pressure ulcer. And it doesn't cause me a pressure ulcer because the levels of deformation, that is, even when I tite it, the level of deformation is too low. So tissues can survive here. I told you that I don't like to do these experiments, and I don't do them anymore, because starting from 2005 or so, we became gradually involved in an emerging field in bioengineering, which is called tissue engineering. And this is basically, the vision was that you can culture cells in a culture dish, give them the certain stimuli that they need in order to form a tissue, and then have a piece of a tissue that you can use to replace failing tissues or failing organs. That was the vision of the field. We use it a little bit differently. We use it as, again, a living model system. So instead of doing animal experiments, we are now doing these tissue-engineered model system experiments where we take cells from different sources, we culture them, we let them proliferate, we then cause them by providing the right chemical or biochemical and mechanical and sometimes electrical stimulations. We cause them to form tissues, so fibers, muscle fibers in this case, and to have organized structures of tissues, so actually living pieces of muscle. And you can work with those. You can keep them alive in the lab for like 3-4 weeks. You can work with those as if they were animal models. They're perfectly alive. Another advantage of tissue engineering is that you can isolate factors. So you are able to basically create tissues that have some features of native tissues but don't have other features. In this case, we have created muscle fibers. So it's not muscle tissue in the sense that it doesn't have connective tissues in it, it doesn't have nerves in it, it doesn't have vasculature in it, which is why, by the way, you can only make it small. You can't make it large because then the cells inside wouldn't be able to survive. But it doesn't have vasculature. If it doesn't have vasculature, it can't be ischemic, right? That's a perfect model where you can isolate the direct effect of tissue deformations from the effect of ischemia. This is just to show you how we produce these tissue-engineered constructs. I did this work in collaboration with my friends, Professors Kees Omens and Dan Bader from the Netherlands and the UK. It's a perfectly aligned muscle without, as I've mentioned, the vasculature. This is formed by just molding a mixture of gel that contains collagen and growth factors with myoblasts, which are pre-muscle cells, and then let the cells culture and create these fibers in the system. And then, as I've mentioned, you can do experiments with this thing that are much like the animal experiments that I've mentioned. So here is our indentor, much like in the rat study. Compressing against the living tissue, and we keep that tissue alive in like a mini incubator that's containing a heating system, temperature control, oxygen, CO2 control. Everything is controlled, which is a wonderful, for me as a scientist, a wonderful experimental system to work with. You can control, you can like switch a button to control each of these parameters where in an animal model you just couldn't do. And then we also apply known levels of deformations and basically cause a pressure ulcer. And you can see how this pressure ulcer evolves. So this is just a quarter of a circle in the tissue around, so under the indentor that is pressing against it. This indentor obviously represents the bony prominence, right? And you can see how cells start to die and how this damage spreads over time. Each of these red dots is a dying cell. It's a fluorescence technique that basically dyes dying cells. And we know exactly which levels of deformation are in here. It's all done under a microscope. So we basically monitor individual cells here. And we can produce, by looking at the time course of this damage, an equivalent tissue injury threshold. This time we call it a cell injury threshold. It's in the level of individual cells. And what was striking for us at the time when we did these experiments were done in the Netherlands, was that not only that the shape of this curve was so similar to the one from the animal models, but also the time course. So you see this, again, reduction in the tolerance of the tissues that I was mentioning. This time course behavior with the maximum rate of reduction occurring at around 2 hours. Does 2 hours remind you something? Pressure, repositioning, right? Both gave the same result. The tissue tolerances are reducing after 2 hours or so. So if we have one system that is affected by ischemia, that's the animal model, another system that is unaffected by ischemia because it just can't have ischemia, that's the tissue engineering model, and they both provide the same result in terms of the reduction in tissue tolerance over a time course, what does that mean? What do you think? To me, it meant that ischemia is not important. Which is really kind of shocking, right? Because when you take a textbook, pressure ulcers are all about ischemia. That's why they measure pressure. That's why they use all these pressure mats, right? To make sure that the pressure is under the capillary closing pressure or whatever. It's not about ischemia at all. At least not in this, time frame of 4 or 5 hours. But this is when you get a pressure ulcer. We know that. From surgery, from ambulances, from whatever. We know that you can get a pressure ulcer in that amount of time. So if it's not ischemia, it must be something else. And we started to look at what that other thing is. We thought, well, maybe it's not ischemia, but it's something that needs to connect to transport. Because when you deform a tissue, when you compress a tissue, you change its microscopic structure as well. So if you think of the really microscopy, the microscopic structure of the tissue, there's a lot of these fibers at the nanoscale, right? At the scale of collagen fibers. There are these fibers, and now you're deforming them. So if I'm a molecule and I'm trying to pass through, but this fiber network is becoming more dense, I can't get through. So deformation is changing the structure not only at the global, at the macro scale, but also at the micro scale. So we started to think, okay, so what needs to go through there? So obviously oxygen. Oxygen is very small. It's a tiny molecule. Waste products, like CO2, that's also a tiny molecule, but also larger stuff. So for example, glucose. Glucose is much larger. But the tissue, say muscle, can't do anything with glucose unless it has insulin availability, right? So also hormones. Hormones are huge. They're monsters. So if you look at the molecular weight of hormones, they are like 5 orders of magnitude the size of an oxygen molecule. So these monster, giant molecules need to pass through this condensed now, very dense network of fibers. That could be an issue. Another thing that happens there is ischemia in some of the subjects, right? In some of the patients, there is ischemia. We know, for example, that pressure ulcers connect with diabetes, and diabetes connects with perfusion. Well, basic physics shows that transport also connects with temperature. So when you have temperature reductions, everything slows down. Everything slows down. And in ischemia, and you see that here on the same animal model, but basically we also took some infrared tomography scans here of the limb when we were compressing, and that caused ischemia, because this, as I was mentioning before, once you do these experiments in animal models, you can't separate between ischemia and deformations, because at the moment you're deforming the tissue, you're also affecting the vasculature. And then the tissue starts to cool down. So on top of the fact that these big molecules need to cross, they also need to do it in a colder environment, right, which slows them down, so the tissues are starved. Well, you can measure these effects as well using fluorescence techniques in a lab. I'm not going to tell you exactly how the details of this technique work for the sake of time, but basically, these are, again, dyed molecules, marker molecules, which you can basically purchase, and you can buy them in different sizes. And then you turn off their fluorescent property by bleaching them with a laser beam. And then you look at how fast these dyed molecules are filling that gap again, which tells you something about how fast transport is going on in the tissue. And again, this is all done with tissue-engineered muscles in these micro incubators that we've developed. And so again, the strength of this tissue engineering stuff is that you can separate, say, the effect of deformation from the effect of temperature decrease, which relates to ischemia. You can look at these factors separately or together. And what you see immediately is that there is a transport issue. Because once you deform the tissue, and as it is being condensed, the large molecules, exactly as expected, can't go through anymore. And if you cool the tissue a little bit, which is exactly what happens in ischemia, so you remember that cold feet, for example, are a sign of a perfusion problem, so that's exactly what happens in ischemia, you get an additional reduction in the what we call diffusion coefficient, which is basically the speed of transport of molecules in the tissue. And now, again, going back to computer simulations, other than looking at deformation levels, you can also look at transport phenomena and simulate them. So think about these tissues, so these muscle fibers, again, that need to be fed by capillaries. If that's a spinal cord injury muscle tissue, the changes that I've mentioned before at the organ scale also take place at the microstructure. Fibers are reducing in size, capillaries are vanishing. You have basically greater distances that molecules need to travel in order to reach from this capillary to this muscle fiber. That's just because of these disuse changes at the microstructure. Now, if you think about what the effect of that will be in a deformed tissue, so in a normal deformed tissue, which is deformed by shear, as you see here, but also by compression, say if you look even at glucose, which is relatively small, if you look at the coverage of the surface of the cross-section of the fiber, it's well covered. It's well covered. If you look at spinal cord injury tissue, you know these blue spots here? Here, blue is not good. Blue is where the tissue is, where the fibers, where the cells are not covered by glucose. So you can see that the cells are inherently starving because of this combination of deformation and which affects these properties of transport of the extracellular space, and the effect of temperature, which is reducing mildly, but enough to cause these transport problems. I'm going to now go to the last, or maybe the first, the foundation of this pyramid that I was referring to the cell level. So if there is an effect of transport at the tissue level, we thought, well, there might be something that goes on at the cell level as well. And basically, we thought that these deformations are also affecting the way that cells are transferring materials, and you know that cells have certain mechanisms to do it. They have these little channels where selectively stuff goes in and out. They have other means to do it, so like endocytosis, they can wrap around particles. All these things, they're mechanical mechanisms, right? So they need to be somehow affected by these levels of deformation. So we thought we should look at the level of cells as well. So cells. This is what happens to a cell that you deform in a culture dish. Doesn't have anything to do with pressure ulcers. Well, we culture cells all the time, so we wanted to look at what happens to these cells when you basically compress them, which is somehow connected to what I've told you about the bony prominences and the way that they affect the tissues. And basically, when you compress a cell in this computer simulation, you see that it's being compressed. That's not a big surprise. But if you just look at the membrane of the cell, the plasma membrane, this envelope of the cell, which is very important in terms of what I mentioned about transport, everything that goes into the cell and everything that goes out of the cell, so waste products, for example, and everything that goes into the cell, so metabolites, need to pass through this plasma membrane. Now, when you compress a cell, the plasma membrane is actually stretching. Well, you can obviously argue that this doesn't have anything to do with what's happening in the body, but it's just an interesting observation. And we actually looked at that into much more detail. We've developed a method to scan cells, real cells, that we look at under the microscope. This is a three-dimensional microscopy, by the way, much like an MRI. It's called confocal microscopy, where you can scan slices of the cells, much like you would do in an MRI machine. And you can reconstruct these cells again in a computer. There is a nice YouTube movie that was filmed in my lab. You can just Google me and find the tissue engineering and my name. You'll see the details of this technique in YouTube. But anyhow, you can do it with basically with living cells. You can scan them into the computer, treat them much like the human anatomies that I've started with, and do virtual experiments with them. Look at what happens to the nucleus of the cell, to the cytoskeleton of the cell, and to the plasma membrane, which is our interest in this case. And you can do these virtual experiments again. Take this real cell, this is a muscle cell, compress it virtually in the computer. It was a real cell that we've observed under the microscope. And then look at what compression would do to its plasma membrane. And you can see again that it's stretching. So these warm colors indicate stretching. And so I was teasing you and saying that this doesn't have anything to do with pressure ulcers in the human anatomy. But now I'm taking you to a little bit of a higher level, where instead of just looking at one cell in a culture dish, you can look at many cells in a structure that would be similar to the tissue-engineered constructs that I've shown you. So here is again a computer simulation. There are many cells here. And now we do the same thing. We compress them. So they start these virtual experiments by being round, right? And then as we compress the construct, as we apply this deformation, look at what happens to them. They begin to flat. So as they're flattening, obviously, the plasma membrane is stretching. And I didn't forget about your coffee, by the way. You'll get it in a minute. As they're stretching, right, and they stretch a lot, something should change in the transport through the plasma membrane. Again, given the influence on all these mechanisms, the ion channels, the endocytosis, all these mechanisms by which cells control transport and by that control their homeostasis, the biological equilibrium. And you can look at the effect of stretching of these individual cells in an actual experiment, so not in a computer simulation. We've built a lot of these, what we call cell stretching devices. Some people told me that it's actually cell torturing devices, where you can basically culture the cells here on an elastic substrate. You can stretch that substrate, and since the cells are attached adhered to the substrate, they stretch with them. And you can do it, again, in a controlled manner and in controlled conditions. And you can look at what happens to the cells. And this is an example of an experiment that we've done. We've published many of those, where you put some dye in the medium of the cells. There's no dye inside the cells, just in the medium. Then you stretch the cells. You wait a little bit, say a few hours. And then you wash the medium with the dye. So everything, all the fluorescence that you see after you've washed that is coming from within the cells. So that means that the cells absorbed it, so that there's an uptake. And you can see that this uptake is increasing So first of all, to show you that there are cells there, so we dye the cells, we dye the nucleus of the cells with blue or bluish, and we dye the cytoskeletons with red. So there are cells here. Now we look at the fluorescence from this stuff in the medium. There's nearly nothing. And then when we increase the level of deformation, we see that the cells absorb it. And this is basically what you see in the graph. As you increase the level of deformation, the cells uptake more. And as you also reduce the size of the diffusing molecule, so if these molecules are smaller now, then the cell will also uptake more of them, right? It makes sense, right? If you stretch very hard, you may even tear this plasma membrane, so you have these micropores, and if a molecule is small enough, it can just go through these spontaneous pores. So it's not a catastrophic failure, it's not a catastrophic mechanical failure of the cell, but just little pores that basically interact with the cell's ability to control its homeostasis. Because if these large molecules that we've used in the experiments can go through, so little things like calcium ions, for example, can go through very easily. Now, muscle cells need calcium ions. They can't survive without calcium. If you give them too much calcium, that will kill them almost instantaneously. Basically, all of it points to the fact that deformation affects transport, not in the sense that it causes ischemia, but in the sense that it impairs the basic mechanisms that the cell have in order to regulate its homeostasis. The clinical takeaway message from this is that in order for all of these homeostasis interruptions to not occur, what you really need to do is to regulate your level of tissue deformations. You don't want to have high tissue deformations because high tissue deformations will cause the cells to lose their homeostasis because the plasma membrane is now becoming so permeable. So now I'm going to show you this more clinical interpretation of the same curve that I was talking about for the last hour. And basically, if you have a patient in a wheelchair who's fat, right, who's overweight, and with just a little bit of muscle tissue that now deforms a lot, you'll be here in the high deformation level, at least with respect to what the muscle feels. And then you'll hit this curve here, which means that you have just a little bit of time before cells will start to die. If you're here, for example, and it is possible, we've seen subjects who use a wheelchair for many years, but they keep the muscle mass. We've seen professional athletes that are able to do that. I guess that physical therapy and any type of activity that kind of stimulates the muscle, even something that comes from externally, so like functional electrical stimulation, can probably do that. You keep your muscle mass, you keep your body weight low, or at least normal, and then you're at the low deformation level, which means that you'll hit the curve here, which means that you have more safe seating time.